السلام عليكم. أنا سارة أحمد حسن، مدرس مساعد أمراض باطنة في كلية طب قصر العيني. إن شاء الله هعرض النهاردة case presentation. Our patient is 37-year-old male patient, married with 3 offsprings. The youngest is 5 years old, working as an accountant, born and living in Banniswave, with no special habits of medical importance. He came complaining of bilateral diminution of vision. The condition started on the 3rd week of December 2020 by gradual onset and progressive course of bilateral painless diminution of vision in both eyes. That was followed shortly after by bilateral diminution of hearing in both ears. Then the patient developed attacks of dizziness that was not associated with loss of consciousness or any neurological manifestations. The patient also complained of bilateral spontaneous epistaxis, moderate in amount with blood clots, but no bleeding from any other orifices. There was history of blue discoloration of hands and feet in winter. The patient also claimed the presence of recurrent fever of 1 year duration, and he cannot specify a pattern, with no localizing symptoms or loss of weight, no history of drug intake or other system affection. As regarded past history, the patient was discovered to be hepatitis C virus positive 5 years ago and received treatment for 3 months with repeated PCR, who was negative. Surgical history was free. Family history was irrelevant. As regarded examination, the patient was fully conscious, well-oriented to time, place, and persons, of average mood and mentality, with good memory to recent remote events, of average belt, and cooperative. His vital signs were within normal with no evidence of fever all through admission. As regarded regional examination, head and neck examination, upper limb examination showed no abnormality. Lower limb examination showed cold extremities with acrocyanosis, otherwise was normal. Chest and heart examination were normal, and abdomen examination was also normal with no evidence of organomegaly and no lymph node enlargement. Ophthalmologic consultation was done with fundus examination. The optic disc showed elevated hyperemic edge with splinter hemorrhage. The macula showed hemorrhage. Retina mid-periphery showed enlarged tortuous vessels with venous bleeding, cotton wool spots, flame-shaped hemorrhages, and rough spots. Fluorescent angiography was done. Both eyes showed acute hypertensive chorioretinopathy with Saturn retinal vein occlusion and dry macula. ENT consultation was done for both the hearing loss and epistaxis. Endoscopic examination showed bilateral blood clots in both nasal cavities with normal ear examination. CT nose and paranasal sinuses were normal. Audiogram showed profound bilateral sensorineural hearing loss. As regarded our patient is a 37-year-old male patient with history of HCV, which was treated with bilateral diminution of vision with central retinal vein occlusion, bilateral profound sensorineural hearing loss, dizziness, epistaxis, and acrocyanosis. Our differential diagnosis was either is it a case of hypercoagulable state, preferably antiphospholipid syndrome, or a case of vasculitis. On the top is granulomatosis polyangiitis, or it's a case of hyperviscosity syndrome. So we move to investigation, beginning with the CBC, which shows mild normocytic normochromic anemia, hemoglobin was 11 with normal platelet count and TLC. PT-PC and INR were normal. ESR was markedly elevated, which was 140. Bilirubin, alkaline phosphatase, and liver enzymes were within normal. Kidney function was normal. Albumin was mildly decreased with 3.4 with the increased total protein, which was 9.5. Electrolytes showed hyponatremia, the sodium was 123, hypokalemia, the potassium was 3.1, and hypercalcemia, the potassium with 11.7 with normal phosphorus. Protein CNS and antithrombin 3 were normal. Antiphospholipid serology was normal. ANCA-C and P were negative, and antinuclear antibody by HEP2 technique was also negative. Blood viscosity was elevated 33, while the upper limit of normal was 1.8. Accordingly, our patient is a case of hyperviscosity syndrome. But which type? Is it a case of cryoglobulinemia, especially the patient has a history of hepatitis C virus 5 years ago which was treated? Or it's a case of multiple myeloma, or Waldenström macroglobulinemia, or myeloproliferative disorder? What goes against myeloproliferative disorder is the CBC which was normal, showing only mild anemia. Let's see. C3 was normal, C4 was consumed, it was 8 mg per deciliter, rheumatoid factor was elevated, more than 1,200. Cryoglobulins was negative. As our patient has increased to the protein, which was 9.5, with mild decreased albumin was 3.4, and hypercalcemia calcium was 11.7, serum protein electrophoresis was done and showed mild increase in alpha-1 and 2 globulins and monoclonal band. Immunofixation revealed the presence of monoclonal gammopathy of IgM kappa. Kappa light chain was elevated 9 gram per liter with normal lambda light chain, with kappa lambda ratio was elevated to 3.7. Protein electrophoresis in urine was negative for protein bands. Serum IgM level was markedly elevated, it was 423 mg per deciliter. Beta-2 microglobulin was mildly decreased, it was 2.9, while the normal was up to 2.2, with negative hepatitis B surface antigen and negative HIV. Carotid and vertebral color duplex showed mild bilateral insignificant carotid atherosclerosis with high bilateral vertebral arteries resistive indices, suggestive of cervical spondylosis rather than distal artery disease. MRI and MRV of the brain were normal. Pelvic abdominal ultrasound and CT scans showed unremarkable study. Bone marrow aspirate and biopsy showed normocellular bone marrow with multiple lymphoplasmacytic lymphoid infiltrate, constituting nearly 30 to 40% of total marrow cellularity with orderly trilineage hematopoiesis. Immunohistochemistry was positive for CD138 and CD19. As regards our patient, the patient has hyperviscosity syndrome as evidenced by increased viscosity, eye affection with retinal vessel tortuosity, bleeding tendency, and neurological symptoms. Monoclonal gammopathy, increased IgM level, lymphoplasmacytic infiltration in the bone marrow more than 10%, and immunohistochemistry. All this goes with the diagnosis of Waldenström macroglobulinemia. What is Waldenström macroglobulinemia? It's a rare clinical pathologic entity. It's characterized by infiltration of the bone marrow by clonal lymphoplasmacytic cells and IgM gammopathy in the blood. Its incidence is 3 per million people per year. The median age is 70. Less than 10% of patients are under 50 years of age. However, there are reported cases in 20s and 30s. Around 60% of cases were males. The etiology is still unclear, with no obvious causative or predisposing factors. Hepatitis C virus infection conferred a threefold higher risk of Waldenström macroglobulinemia. Eradication of HCV is associated with reduction in hematological malignancies. However, some studies showed no reduction in hematological malignancies in patients treated with direct-acting antivirals. The reduction was only in patients treated with interferon. Larger studies have suggested an association with chronic immunostimulation and autoimmune disorders. Patients can develop symptoms related to either infiltration of hematopoietic or other tissues in the form of anemia, lymphadenopathy, and hepatosplenomegaly, and/or symptoms related to the IgM monoclonal protein in the blood presenting as hyperviscosity or peripheral neuropathy. Most of the patients have constitutional manifestations, but some may be asymptomatic. This is termed smoldering Waldenström macroglobulinemia. Patients may experience the following: fundoscopic abnormalities in 34% of cases as our patient, constitutional symptoms in 23% of cases, bleeding tendency as our patient in 23% of cases, neurologic symptoms in 22% of cases, symptoms related to hyperviscosity in 31% of cases, lymphadenopathy in 24%, and splenomegaly in only 19% of cases. As regards cryoglobulinemia, either type 1 or 2, they are present in 10 to 15% of Waldenström macroglobulinemia cases. If present, it can present with severe manifestations as Raynaud's, tissue necrosis, and glomerulonephritis. And as regards the rheumatoid factor, IgM can be present in hematological malignancies as Waldenström, more commonly associated with the presence of cryoglobulins, but can also occur in Waldenström without the presence of cryoglobulins. As regards complement 4, in Waldenström, it's usually associated with normal complements. Reduced C4 is usually associated with cryoglobulinemia. Case papers of Waldenström macroglobulinemia associated with reduced both C4 and C1q without the presence of cryoglobulins have been described. Diagnosis of Waldenström required the presence of IgM monoclonal gammopathy in the serum, and more than or equal 10% of the bone marrow sample demonstrate infiltration by small lymphocytes, which exhibit plasmacytoid or plasma cell differentiation with intratrabecular pattern. Back to our patient received 5 sessions of plasmapheresis with increased plasma viscosity, followed by 4 sessions of rituximab and chemotherapy with termed bendamustine, with marvelous improvement of his condition. And thank you.